Good morning, ladies and gentlemen. It's our pleasure to have Dr. Kwan Zhenli to give a talk on today's breakfast symposium at the next session. Dr. Kwan is the head of the Dermatology unit and a consultant dermatologist at UMMC. And Dr. Kwan has a keen interest in cutaneous oncology and dermatosurgery. Her area of research is in the field of psoriasis and artificial intelligence in dermatology. Today, we would like to invite her to give a lecture on artificial intelligence in dermatology. Over to you, Dr. Kwan.
Good morning, ladies and gentlemen. Today, I'll be talking about artificial intelligence in dermatology, the rise of the machines. What is AI? When we think about AI, we often have impressions about science fiction movies, novels, and TV shows such as Star Trek, in which you have androids like Data, pictured here, or even holographic doctors who can interact with patients. But AI is actually not a new concept. In 1642, the first mechanical calculating machine was built by Blaise Pascal, and foundations of neural network were established in 1943. In 1950, Alan Turing talked about the Turing test as a way of testing a machine's intelligence. And the term itself, artificial intelligence, came out in 1955 during a conference devoted to this topic. Subsequently, with the development of AI, now we have autonomous robots that clean our houses with vacuum cleaners, self-driving cars, even Siri in our handphones. What is the Turing's test? This is Alan Turing. As you can see, he's a mathematician who came up with this way of testing intelligence. And this concept was actually referred to in a movie about his life, The Imitation Game. So you have an interrogator who asks questions to both a computer and human responder. And you pass the Turing test if you cannot determine whether the respondent or the answer is from a human or a computer. What is the driving force that has led to the popularity of AI in our daily lives? So firstly, is computing power with the modern computers and all kinds of facilities that we have, as well as big data. As you know, we now have things like Google and a lot of internet providers which can give a lot of big data. And these data sets can be used also to fuel advances in AI with the help of the computing power. So what are sources of big data in healthcare that we can use? These include smartphones, payer records, government agencies, patient portals, research studies, generic databases, electronic health records, public records, wearable devices such as Fitbit, and search engine data. As you know, you can even access things like Google Analytics nowadays. Various skin disease data sets comprise of images that can be used for analysis by AI algorithms. These include DermoFit, iSeq, Derm101, DermNet, DermIS, Atlas Derm, DanDerm, and Xiangya Derm. And you can see that these data sets are available from a variety of countries in the world. So what is machine learning, or ML? So ML is the art of giving computers the ability to learn and behave without being programmed, while deep learning, DL, is a branch of machine learning. And in DL, algorithms known as artificial neural networks simulate the structure and function of the human brain. And you then have computational models comprising of multiple processing layers, which are able to develop data representation with different levels of abstraction. So you can see here in classic machine learning, with image inputs, you tell the machine what to look for. And this is known as feature extraction. Subsequently, you have classification, and then you differentiate into the different classes. Here in this example, class 1 and class 2. However, with deep learning, you do not tell the computer or the machine what to look for. The computer will look at the image and determine on its own. So you have image inputs, and with the hidden layers, your input layer and output layer, you have feature extraction and classification done by the computer, leading to then whether you can differentiate into class 1 and class 2. Applications of AI in dermatology, the most popular is actually skin cancer detection, such as with dysplastic nevi, melanoma, and basal cell carcinoma. Next, you can also use AI to classify erythematosquamous diseases such as psoriasis, seborrheic dermatitis, lichen planus, pityriasis rubra pilaris, pityriasis rosea, and contact dermatitis. Other applications include for onychomycosis, acne, as well as alopecia. These are the various steps that we use towards the classification of images. Firstly, image acquisition. Secondly, image processing, which encompass image enhancement, image restoration, and hair removal. Next, you have image segmentation, feature extraction, and finally, classification. So image acquisition, the two most common and popular methods are photography as well as dermoscopy. And you can see this in a variety of data sets that we talked about earlier. Other methods include confocal scanning laser microscopy, ultrasound, magnetic resonance imaging MRI, OCT, as well as multispectral imaging. So after we have acquired the images, what do? We then have to process the images to optimize the quality. So this includes image enhancement, such as image scaling to standardize the size, color space transformation, and contrast enhancement to sharpen borders and to accentuate the difference in brightness between the background and the foreground. Next, you have image restoration, in which you can reduce the noise as well as the blur. And finally, hair removal, so that it improves the skin cancer images by removing the hair using morphology methods and curvilinear structure detection. This is a picture that shows contrast enhancement. So on the left is before, and on the right, you can see an after image. Next, you have image segmentation, in which you partition the image into disjoint areas that are homogeneous with regards to a chosen property, such as luminance, color, and texture. Examples include color-based, age-based, region-based, etc. Next, you have feature methods. So this include techniques that are very much analogous to how humans would analyze dermoscopic images. And techniques include pattern analysis, ABCD rule, Menzies method, 7-point checklist, cache algorithm, which refer to color, architecture, symmetry, and homogeneity, as well as discrete wavelet transforms, DWT. So these are various classes that can be used to define the features, such as shape features, in which you look at the irregularity of the border and asymmetry of the lesion, color features, texture features, which relate to the human visual observation of appearance, as well as high-level features such as granularity, blue-white veil, blue-gray dots, circular colored spots, and dark and white areas. And some of these concepts we also use in analysis of dermoscopic images. So finally, you have the classification techniques, including artificial neural networks, ANN, convolutional neural networks, CNN, support vector machines, SVM, logistic regression, decision trees, random forests, in which you have multiple random decision trees, and adaptive boosting, AdaBoost. We'll touch on a few of these. So the first of all would be artificial neural network, ANN. So these are computational models inspired by the human brain. You have simple processing units, artificial neurons, which mimic your human neurons in parallel. You can see in this image, it illustrates a shallow neural network in which you have 3 layers of neurons. Firstly, your input layer, which accepts independent variables or inputs. So in a lot of dermatology AI systems, these refer to images, whether it's dermoscopic or clinical images. Next, you have one hidden layer, and finally, an output layer, which generates your predictions. A lot of times it is in terms of classification of the images into different classes or diagnoses. With deep ANN, you have multiple levels of hierarchies, which then lead to higher level of abstraction at each successive layer. So these systems are more accurate, and you have improved accuracy as more neuron layers are added, up to 9 or 10. And usually you have between 3 to 10 neuron layers in your system. Next, we have convolutional neural networks, CNN. So this is a deep ANN. And this kind of systems are used to classify images, cluster images by similarity, such as when you do photo search, as well as recognize objects within scenes. Thirdly, you have a support vector machine, SVM model. So in developing your AI algorithms, often you have a training data set as well as a testing data set. So in an SVM model, each training example in the training data set is marked as belonging to one of two categories. And then the algorithm builds a model that assigns new examples, let's say from your testing data set, to one or the other category. So you can see in the illustration here, either you go to class A or class B. Now, is AI a threat to us? In 1997, for the first time, we had Garry Kasparov, a chess champion, defeated by Deep Blue, which was a computer system. And so this is very, very demoralizing, and you can see how upset he looks here. So similarly, for dermatologists, when we see headlines such as this, AI outperforms human doctors in spotting skin cancers, the algorithm makes it easier and faster to get an early diagnosis. Is this a threat to us? Will we lose our jobs? What is the role of dermatologists then in terms of diagnosis? In 2020, the AAD conducted a survey among dermatologists in the US, and they remain divided on artificial intelligence and its impact on dermatology. About half of the dermatologists had a positive impression, while the other half either had a negative impression or they were unsure about the impact on our practice. Why is this so? A lot of them feel that the AI is a threat to us and it will supplant us or make us, be replaced by the computer system. And they also had other concerns such as, how do these systems actually work and things like that. So we can see, based on a lot of studies, that the AI systems can analyze images either similar to the performance of human raters or even better than us. So for the first three studies by Cordella, Henseler, and Brinker, they looked at the differentiating melanoma from Levi, and you can see better specificity and sensitivity compared to humans. Shander et al. Looked at non-pigmented tumors, and Meron et al. Looked at the ISIC dataset, and they said that the AI system actually outperformed dermatologists. Henseler et al. Also looked at the role of AI in terms of analysis of the dermoscopic image, and it found that the system actually outperformed dermatologists, 95% sensitivity and specificity, 76.7% versus the dermatologists. However, with additional clinical close-up images and clinical information, which they said is more true to real life. After all, as dermatologists, we do not just look at images. We also have a lot of metadata, such as the history and other information that helps us to make a diagnosis. So with this, the mean sensitivity of the dermatologist actually increased to 94.1%. But then you see with the AI system, it was 95%. And in Shandel et al.'s paper, they also said that the AI algorithms achieved more correct diagnosis than human readers. This sort of performance was also seen with clinical images in which the AI performed on par or better than human raters. So this is all sounds rather depressing, but we will see in the limitation section later that AI doesn't really work all that well. So these are actually studies referring to the performance of algorithms in terms of analysis of histopathology images, which is also pretty impressive. We did a study in collaboration with our Faculty of Computer Science and Information Technology, looking at the data set from the International Skin Imaging Collaboration. This is a publicly available data set on the internet, which we can download for use for research and analysis. So our approach was this. In the ISIC data set, they had 9 different classes, which were melanoma, basal cell carcinoma, squamous cell carcinoma, nevi, actinic keratosis, benign keratosis-like lesions, vascular lesions, as well as dermatofibromas. And then we looked at whether we could differentiate using the computer system between melanomas and non-melanomas, as well as cancers and non-cancer images. So these were our method. We had image acquisition, which is basically pulling the images from the data set, pre-processing, model selection, in which we used 2 different methods. One was a classical machine learning method in which we had feature extraction and subsequently classification using SVM and logistic regression. We also had another method which was deep learning based, where we had data augmentation, and we used classification using CNN based on the VGG16 and ResNet architecture. So you can see there were about 25,000 dermoscopic images, mostly of melanocytic nevus, 12,000 over, but we also had images of melanoma, basal cell carcinomas, benign keratosis, actinic keratosis, SCCs, vascular lesions, as well as dermatofibroma. We used data augmentation to increase the amount of data, and this is especially useful for deep learning approaches to avoid overfitting. So examples include horizontal and vertical flipping and rotation with different angles. So this actually augments the amount of data you have in your data set. Next, we also use transfer learning. So in transfer learning, we have a pre-trained model, which refers to a model created and trained to solve a similar problem. You have three requirements, which are the development of an open source pre-trained model by a third party, repurposing the model, and fine-tuning the problem to suit your current system. So we use two networks, which are VGG and ResNet. So our results, we found that both deep learning approaches performed better than classical machine learning with handcrafted features. So in other words, when you leave the computer to decide on its own what sort of features to look for in order to classify your images and get your diagnosis, is better than telling the machine what to look for. So we can see here in terms of accuracy for both melanoma diagnosis and skin cancer images, the deep learning approaches, which are your VGG16 and ResNet, perform better than your SVM and your logistic regression approaches. When we had the use of pre-trained models in which there's, let's say, a system in which someone else already trained using other images, the accuracy of your deep learning improved. So for example, for melanoma, 88.1 and 90.3, and skin cancer, 84.1 and 89.2% accuracy, which was better than what was achieved if you don't train the models beforehand with transfer learning. So in conclusion, our best classification accuracy for melanoma versus non-melanoma was 90.3%. And for skin cancer versus benign lesions, 89.2%, which is not bad, pretty impressive. So in conclusion, deep learning models outperformed classical machine learning models in which we had larger amounts of data and proper augmentation approaches. However, when you have a limited amounts of data, both models show similar type of performance. Now, I mentioned earlier, AI is not the be-all and end-all. It doesn't mean that with AI, humans no longer play a role in terms of diagnosis of skin cancer images. A lot of AI performance depends on the amount and quality of data available. The term used is, pardon my French, garbage in, garbage out. So if you have good quality images, you have a good performance. If you have poor images, you cannot really say that even if the AI reports a good performance, that it's actually very useful. So problems involve unbalanced data sets, inter-class similarities, intra-class dissimilarities, quality of real-life images, minority ethnic populations, and rare conditions. So unbalanced data sets, as we can see even in the ISIC dataset, there are 12,000 images of nevi, whereas you only have about 5,000 images of melanoma. Interclass similarities and intra-class dissimilarities I will illustrate later with a few pictures. And the quality of real-life images. When you have these kind of databases, of course, they are going to take very, very good quality images with a good, proper cameras. But in real life, we often get smartphone images which are not so clear. And minority ethnic populations. Majority of the data sets for these images come from Caucasian populations. So when you apply it to Asian skin or even black skin, the kind of performance will actually not be so accurate. And rare conditions might not be picked up and might not be represented equally in your data sets. So this is an example of intra-class dissimilarities. As we know, these are all basal cell carcinomas. Some depends on which subtype you have, which is your nodular, BCC, superficial, morphiform, and your basal squamous cancers. So all these belong to the same class, which are BCCs, but they all look different. On the other hand, you have inter-class similarities. So this is a very cute example of dogs and fried chicken. So maybe a human, we can tell which is a dog or a fried chicken, but the computer might not be able to differentiate because both look pretty fluffy. So this will lead to confusion and poorer performance of your algorithm. Other limitations of your AI include a lack of history and clinical information. So as I mentioned, we use a lot of metadata when we make our decisions in the clinical setting, which the computer does not have access to and may not be able to interpret as well. Next, you have a black box approach of algorithms. As you can see in your neural networks, sometimes you don't tell the computer what to look for. So you just feed it a set of images and the computer will classify for you into A and B. But we do not know how this computer actually processes it. How does it actually come up to that conclusion? It's all a black box, a mystery. Next, there's still a need for biopsy and histopathology to confirm your diagnosis. So even with image analysis, we cannot be 100% sure. Finally, in terms of clinical governance, because these computers are not actually legally liable, and as I mentioned, black box approach, you do not even know sometimes how these things work. So clinical governance, how can you actually make the, in terms of being responsible for the decision, the computer cannot be legally liable. It still goes back to the clinician. Next, you have public acceptance. So a lot of patients cannot accept the fact that the computer is the one telling them what the diagnosis is. They still feel more reassured with a doctor's diagnosis. And finally, human touch in medicine, that cannot definitely be replaced by a computer. So in summary, AI shows immense promise in dermatology because we are a visual intent specialty. And there's a lot of availability of data in terms of images, whether it's clinical, dermoscopic, or histopathology. And all these images can be used for analysis by computers. And finally, performance of algorithms, which have been shown to be on par, if not surpassing, human raters. However, there are limitations and concerns that need to be addressed before we have widespread acceptance of use of AI in dermatology. I would like to acknowledge the role of my collaborators from the computer science side, which are Mr. Bezat Mahasani. He's the research assistant who did a lot of the analysis and the research in our study, and also Dr. Ram Gopal Raj from the Faculty of Computer Science and Information Technology in UM. Thank you very much for your kind attention.
Thank you, Dr. Kwan. Thank you, Dr. Kwan, for the very interesting talk. And definitely artificial intelligence will play a big role or a certain role in future of medical practice. Okay, we have a question from the floor. Dr. Kwan, do you think that in the future, dermatologists trained with artificial intelligence support may no longer be able to make a diagnosis without the support? Or in the other words, they cannot perform in the less developed world where AI facilities are unlikely to exist?
Okay, thanks, Sean, and thanks, Prof. Chan, for the question. So this is a very important point to make because when you go to developed countries, like I attended a conference in Australia, for instance, there are already companies that are selling this technology. So you can actually go to like Google or the App Store, right? And you can download apps that will tell you, oh, this is what diagnosis. But having said that, I looked at the way these work, and they actually tell you in terms of percentage what the computer algorithm tells them, you know. And then the other thing is, can you all still hear me? Internet connection's unstable. Yeah, so the public can actually download these apps, but I think in terms of clinical governance, as mentioned, there'll be definitely an issue. And as of now, I think the AI, how do I say, the performance of the AI is not there yet as to be able to make it 100% reliable. As you can see, there are still percentages of uncertainty. So let's say if the wrong diagnosis is made, right? So who is going to be responsible? You cannot pin the blame on the computer, right? So the human role is still very important. And because a lot of how the computers are trained also is based on all the features that we see on dermoscopy. So the humans, we are still being trained how to read these images. From Prof. Sarah, she's asking whether this is really necessary since we need a biopsy anyway. So basically with the use of dermoscopy, what's happening to be suspicious or not, and then we decide, oh, if it looks clearly it's benign, we do not actually need to do a biopsy. Unless we're unsure or it clearly looks like a malignancy, then we will proceed with the biopsy and also further intervention. patients are going to sue the agent behind the AI if the diagnosis is not right. I think this is a bit loaded. This is probably a gray area as of now, because if you think about it, let's say if you are a public member of the public and you are actually using the app on your own, then yes, it's really up to your own self how you want to take the results. But let's say if the doctor is the person using the AI, I think the doctor will still be the one communicating the results. So there will still be a duty of care from us to the patient.
Okay. Yep. So, Dr. Kwan, since like there should be more research ongoing to identify and to address all these issues and to develop the technology. Do you see any difficulty in terms of technical knowledge for all the teams to collaborate, because all the teams are coming from different areas, for example, computer sciences, medical sciences, dermatologists, clinicians?
Yeah, so I think that it's very important to collaborate and to be able to speak each other's language. So, of course, there's a lot of jargon in each field, and in the sense that we need to learn how to find a common platform to communicate. So the other thing, someone is asking about the DNA sampling from the surface of the lesion. I don't think that's really possible at this point in time, because from the surface, all you're going to get is your commensals and probably some other stuff that's from the environment rather than the cells itself. So if you're talking about DNA sampling, maybe in the future that might be a good idea. But for now, this technology is probably not too extensively used, especially in the clinical side. And if you think about it, if we want to do this kind of methods, yes, it might be feasible, but the problem is also cost and also availability.
All right, thanks for the answers, Dr. Kwan. Are there any more questions from the floor?
Does PPM train a deep learning? No, we don't have adequate images. As you can see, those data sets, they have so many thousands of images, 12,000, talking 25,000. And I don't think from a single center you can achieve that sort of number.
Okay, thanks, Dr. Kwan. Thank you very much. I think there's no more questions from the floor. I shall pass it back to the organizer.
Thank you, everyone, for your attention.
Okay, thank you everyone for joining us. So we'll end the session today and hope to see you guys next week. Thank you to all the panelists and also the moderators for their sharing today.